And we're back now with Sunday House Call. You know, hip replacements are so common, but how do you know if you really should get one or instead have a procedure that they're now calling hip resurfacing? Dr. Samadi, let's start with, getting a new hip. When the doctor says you need a new hip, how do you know?
Well, this is a very important topic because we're seeing about 400,000 surgeries of hip replacement in this country. Obviously, your hips are major weight-bearing joints, and the whole body, the whole structure leans on that pelvic area. So you want to make sure that you are taking care of this by doing exercise, by losing weight, doing all the good things. But overall, some wear and tear, something called osteoarthritis, can affect those joints. And what happens is you're going to have an unbalanced pelvis, a lot of pain, immobility, and it's going to interfere with your life, and that's when these kind of surgeries comes in. I want Mark to talk about the medical treatment of this, but as far as the surgery is concerned, this is a general operation. You go to the operating room, you get general anesthesia, you will stay in the operating room for about a couple of hours. There's an incision about 4 to 6 inches, and we will expose the head of femur, which is a bone that goes into the socket called acetabulum. And then what happens is you can basically put a new, as you can see in the pictures, you can see a new prosthesis going in. And that's exactly the form of this. This is basically a form of ceramic, and it gives you the mobility. And there are some complications as a result of this, but in the hands of experienced surgeons, this worked really well.
It really is unbelievable when people say they have a mark. I mean, how do you know when a patient comes to you, what do you look for, and then what do you tell them?
Well, as David started to say, you have to observe this over time, Eric. How bad is the deterioration on an X-ray? How much is your mobility limited? How much is it interfering with your lifestyle? Are you racked with pain? Now, have I tried things like physical therapy? Has that helped you? Is exercising helping you? What about weight loss? That's huge. Now I also have pain medications I can use. Unfortunately, the non-steroidal drugs like Motrin, Advil, Naprosyn, over time, they're bad for your kidneys and bad for your liver. So if you're stuck on those every single day, that's not a good solution. So I can't suggest that. That's when I start working in coordination with an orthopedist. Maybe it's getting time for this. The operation itself is only a couple of hours, but then there's months of rehabilitation afterwards, and you could get wounds, and you can get blood clots. So we don't go into this casually.
And some patients probably react better to these hip replacements than others.
Well, it's very important that you bring this up. Obviously, it's done mostly around the age of 60, 65, and they last about 15 to 20 years. That's what these hips are good for. But we see this sometimes in younger guys, and that's where the resurfacing comes in, that you would still keep the head of the femur, and you just resurface it and may just put a new ceramic on top. It's a much easier operation. The recovery is faster until they end up with a real prosthesis. I think it's also important that a lot of patients who are on steroids, they may get something called osteonecrosis. They may actually lose that part of the femur. If you are also not only steroids, but exercise is very important. Rehab after these exercises and surgeries are important.
Dr. Siegel.
The resurfacing, I wanted to find out more about that.
Well, I actually asked our chief of orthopedics at NYU about this morning, and he says it's only in select patients, in select hands, people that are really, really skilled at it. Because what you're doing there is you're preserving the head of the femur, that ball, and you're sticking a plastic cover on that ball, but you're replacing the socket. A lot of times the ball is not in great shape either, so you really got to know what you're doing, Eric. And the other point is, can you do this minimally invasively? Like David does prostate surgery minimally invasively, can you do this minimally invasively through a scope, get the patient in and out the same day? That's the miracle that we're seeing right now.
It's starting to happen. With a smaller incision, faster recovery. You also want to think about patients that may have fractures. Sometimes they may have cancers that has metastasized to that part of the hip. So these are all differential diagnoses that you want to think about and examine. And of course, with MRIs and CAT scans, you can find out all of this information.
One final point is, I'm going to surprise him now. In the older patients, we sometimes use cement on these joints. In the younger ones, we don't tend to use cement, but then the rehabilitation is a lot longer. It restricts your motion a little bit, that cement, but we tend to use it over a certain age, 60, 70, 80.
I am impressed because a lot of times in younger guys, you would have the actual bone that can grow in, and you would have a biologic fixation, and that's the important point, rather than a cement that can just stick to the acetabulum in an older patient.
As long as you don't use crazy glue. Okay.
The crazy glue is coming. That's the next topic. That's gluten. That's the glue.